Chairman, we are ready to begin.
Thank you, Danisha, and welcome everyone to our board meeting this morning. And those of you as visiting our board meeting and our board members are on the line. And Danisha, would you please call the roll of board members?
Yes, Chairman. I'll begin with Norman Boyd,
Here.
Tommy Hopkins, Tommy Hopkins,
Here.
Cynthia Rucker,
Here.
Roger Folsom,
Here.
David Cruz,
Here.
Anthony Williamson,
Here.
Shane Mobley,
Here.
Robert Coles,
Here.
Kathleen Ruth.
Here.
Chairman, that concludes my roll call.
Thank you, Danisha, and welcome to the board members, and thank you for taking your time this morning to participate. We do have a quorum to conduct business, so I will call the meeting to order at this time. The first thing on our will be the minutes of the previous meeting, but in looking at our agenda today, to give you a quick overview, we have 4 items that will be presented to us for consideration on a vote, and we'll have an informational presentation on the No Patient Left Alone Act, the House Bill 663. So those are the main items that are on our agenda. First on our agenda is the approval of the minutes of the June 13 meeting, and I'll call on our secretary, Dr. Cynthia Rucker, if she's had a chance to review those minutes and could in fact recommend approval.
Thank you, Chairman Board. I have reviewed the minutes, excuse me, for June 13th.
Minutes have been reviewed and asked for approval. Is there a second?
Dr. Cole, second.
Dr. Coles has seconded that. All in favor say aye.
Aye.
Opposed? Abstaining? Hearing none, the minutes of the previous June 13 meeting are in fact approved. My opening comments this morning, we've had a change in a board appointment. Nelva Lee has resigned from the board to pursue other initiatives. And joining our board is Dr. Kathleen Ruth, and we welcome her on the board. And at this time, if you would, Dr. Ruth, like to make some introductory comments, we would appreciate it.
Great. Well, thank you so much, Norm. I'm very honored to be in this role and look forward to working with the board members to successfully improve the delivery of quality of care to Georgians' Medicaid population. I have over 20 years of professional experience as a health scientist and epidemiologist. I previously served 17 years in the U.S. Public Health Service at the Centers for Disease Control and Prevention, conducting health science studies in HIV and maternal child health. And again, I'm honored to serve and look forward to meeting all of you in person. And thank you so much.
Thank you, Dr. Ruth. And again, welcome to the board. And again, like to thank Nelva Lee for her service to the Board of Community Health. With that, the next on the agenda is we're going to do this remotely with Commissioner report. Commissioner Carlson is remote today, and Cedric is going to make him appear on the screen. So we'll move to the commissioner's comments.
Yes, sir. Thank you, Mr. Chairman. And I might hope everyone can see me. Some people would say leaving me off the screen is of a greater benefit, but we'll move forward. Thank you, Mr. Chairman, and good to meet you, if you will, Dr. Ruth. Look forward to working with you and value the expertise that and experience that you bring to this board. And I'm sure we'll all benefit from that and look forward to you meeting our team in the days ahead. As the chairman mentioned, I am remote today, along with Stuart Portman, our Medicaid director. We're participating in the NA panel at the request of the Georgia Hospital Association. Look forward to, have already had a chance to meet with several of the hospitals across the state and the leadership team at GHA, and very appreciative of the role they play in the stakeholder process, providing invaluable feedback throughout the year. And a lot to discuss. And we also just recently learned that Governor Kemp will be joining the agenda just prior to us. So look forward to being in the audience with the governor here shortly after lunch and hearing his remarks. And then Stuart and I will discuss things of great import to the hospital community. But as the chairman mentioned, today's agenda does reflect a lot of hard work with items that are up for final adoption. And we do appreciate not only the work, the complex work that the staff has gone through to get us this point. I'm always very appreciative of the public input from stakeholders, both associations, organizations, but also individuals. Thank you for taking full advantage of the written and in-person opportunities to engage in the process. You are the stakeholders, the constituencies that deliver many of these services, and that input is never taken lightly. And again, thank you for the participation in this. But there is one special announcement before I go to some employee milestones. There's a unique announcement I'd like to make outside the items on the agenda. I'd like to share that the 4 waiver rate increases that were submitted to CMS in May and June have been approved by CMS with a July 1 effective date. This is in regard to EWP, ICWP, NOW, and COMP. These rate increases were proposed to enact the results of the 2023 DCH rate study that was conducted in response to Senate Bill 610 of the 2022 Georgia legislative session. COMP also included new services and sites of care, which were also approved with a July 1 effective date. So we'd like to thank the quick work of the DCH team, but obviously the ongoing collaboration with DBHCD on NOW and COMP specifically, and the numerous stakeholders and legislators that have been involved in this process for literally years. Our members will receive care that is reimbursed based on a current cost-based reimbursement rate. So we also thank CMS for their quick review and turnaround. This was a very quick process in terms of how these things go from both the state side, also up to CMS. And so I think it shows the import that these services, how much it means to these communities, both at the state level and CMS. So thank you to everyone involved, and we'll begin processing a lot of these and working them from a financial standpoint to be prepared for these providers to take full advantage of that. So thank you. And as you know, there's a lot of work on the agenda now, but there's a lot of work still being done. August always has 2 meetings, and I know Chairman Boyd and Denisha Williams will be speaking to that and getting information on that. That will include both the budget presentation, SHBP's important role in those board meetings, walking everyone through the plan year ahead and open enrollment and the impacts on members. But also it's not lost on us. I don't want to be silent to it that while we are moving a lot of things that came about during the legislature, we know that there's a lot left in the pipeline, if you will, namely all the regulatory changes to certificate of need. Please know that that's a very, very active process at DCH. There's been a lot of progress made in between August and September, knowing that we do have full agendas for August anyway, but we're going to see where we stand. And I think through the August and September meetings, you'll begin to see those certificate of need proposed rules going out for public review. So thank you to the health planning team and legal that has taken an active role in that. And we'll be having some stakeholder engagement, as you would imagine, to move forward on that. So again, just didn't want to be silent to that issue, as I know it's so important to so many people. So being sensitive to time, Mr. Chairman, I will move to the employee milestones. We have some great ones to begin right off the chute. Jeffrey Rozier with the Office of Inspector General, 25 years. Francis Yelton with MAP, 20 years. Jessica Tarver with Financial Management, 20 years. 25, 20, 20 to lead it off. Thank you so much for your dedication to the department over the years. With 15 years, we have Daphne Callis with IT, Alvin Smith with Facilities and Support Services, both with 15 years. Joanne Benjamin with HFRD with 10 years. Melanie Simon, General Counsel with 10 years. Terry Conrad with Financial Management, 10 years. Nicole Hodge with MAP, 10 years. Dahada Carrington, HFRD, 10 years. Thank you, guys. Geraldine Montgomery with MAP, 5 years. Caitlin Ward with Government Relations, 5 years. Jamie Rowe with IT, 5 years. Angel Andrews, IT, 5 years. Kalima Thomas with SHBP, 5 years. Cole Edwards, who recently just graduated a long leadership program. Thank you for your devotion to that, Cole. He's 5 years with the State Office of Rural Health. And I've enjoyed adding these 1-year celebrations because they're worth celebrating, obviously. DeLauren Hicks in the Commissioner's Office, 1 year. Brooke Parker, Financial Management, 1 year. Latoya Milner, Financial Management, 1 year. Ladina Pajud, MAP, 1 year. Kwana Thompson, MAP, 1 year. Patrice Bowles, HFRD, 1 year. And Dominique Johnston, HFRD, 1 year. We're very grateful for everyone's commitment to the department, the immense work that is always before us, but I couldn't be more appreciative to be a part of this team, and your commitment to serving people often in a very selfless manner. So with that, Mr. Chairman, sensitivity to time, I know we need to get to the agenda, but sorry I can't be with you today, and look forward to seeing you a few times in August. Thank you.
Are there any questions, comments for the commissioner from the board, please? Hearing none, thank you, Commissioner, for that update. Thank you for joining us this morning. We'll move into the agenda items we'll be asked to consider for vote. And for our new member of the board, I'll do a quick overview of a process that we typically follow. And that is that proposals that are brought before this board for consideration will first come before this board for approval of what we call initial adoption. And initial adoption means that that item then moves to public comment and public input before we are, and after that input, which typically is about a 30-day time frame, the department looks at that input and makes any changes that they see necessary from that input, and then bring the items back to the board for final adoption, which is the 4 items we're going to consider this morning have previously been out for initial and are back for final adoption. So that's kind of the process that we follow. And as the commissioner mentioned, there's a lot of work goes on behind the scenes before these proposals are brought forward, as you can appreciate. And the board is given copies of these proposals along with the public input prior for our consideration and provided to us in advance. So the first item this morning on medical assistance plans, we'll call on Kim Morris, Director of Reimbursement. And Kim, you may proceed. Excuse me, your volume needs to be up a little. I have difficulty hearing.
Okay, I'm sorry.
Okay.
Are you able to hear me now?
Yes.
Okay, good. Good morning, Chairman Boyd, members of the board, Commissioner Carlson, and Mr. Hood. Today I'm presenting for final adoption pending Medicare and Medicaid services acceptance with an effective date of July 1, 2024, a proposal to increase select reimbursement rates for speech language pathology, audiology, physical therapy, and occupational therapy to 85% of the 2023 Medicare Part B fee schedule. For fiscal year 25, the General Assembly, through House Bill 916, appropriated total funds of $14,281,948, with state funds of $4,845,862. There are 77 CPT codes that will be updated. I will not bore the board with reading all 77 CPT codes. The department will not adjust the reimbursement rates for CPT codes that are not priced by Medicare or reduce the reimbursement rates in those instances where an application of the 2023 Medicare rate will result in a reimbursement rate reduction. An opportunity for public comments was held on June 18, 2024 at 10 a.m. via Zoom audio. The department received one oral comment from Aileen DeGratis, Georgia Therapy Tri-Alliance. We received 4 written comments. Those were due on or before June 25th, 2024. The written comments were from Kelly J. Ball, Representative, Georgia Speech Language Hearing Association, Dara Shah, PT, DPT, President, American Physical Therapy Association, Stephanie Johnson, President, Georgia Occupational Therapy Association, Amy Lucero, Representative, Georgia Therapy Tri-Alliance. All of the commenters thank the department for this increase to the 2023 Medicare Part B fee schedules. The commenters stated that the increase in reimbursement rates would help address workforce shortages in pediatric therapy service and help with recruitment and retention of therapists. The department thanked the commenters for their oral and written comments. At this time, I'll pause for any questions and respectfully ask the board for approval.
Any questions, comments from the board for Kim, please? Hearing none, is there a motion for approval for final adoption?
So moved, Hopkins.
Motion has been made for approval of final adoption. Is there a second?
Shane Mobley, second.
Shane Mobley has seconded that motion. All in favor, say aye.
Aye.
Aye. Opposed? Abstaining? Hearing none, it is approved, Kim, and thank you very much.
Thank you.
The next item for consideration will be presented by Maxine Elliott, Deputy Executive Director of Service Delivery on Medical Assistance Plans. So Maxine, you may proceed.
Good morning, and thank you, Chairman Boyd, Commissioner Carlson, Joe Hood, and all the esteemed board members. For those of you who are not familiar with me, my name is Maxine Elliott, and I am the Deputy Executive Director for Service Delivery and Administration with the Medical Assistance Plans Division. I am here today to present the summary of public comments and request for the final adoption of the Qualified Residential Treatment Program Rate Development effective July 1st, 2024, pending approval, final approval by the DCH board and that of the Centers for Medicare and Medicaid Services. The Qualified Residential Treatment Program, otherwise denoted and referred to as QRTP, is a new designation created by the Family First Prevention Services Act. This program aims to provide a trauma-informed treatment model to address the needs, including clinical needs of children with serious emotional or behavioral disorders. The Qualified Residential Treatment Program must meet several criteria, including being licensed and accredited, utilizing a trauma-informed treatment model, facilitating and documenting family involvement and outreach, providing at least 6 months of post-discharge family-based aftercare, having registered or licensed nursing staff and other licensed clinical staff on site and available 24 hours a day, 7 days a week. This initiative is a joint effort between the Department of Community Health, the Department of Human Services Division of Family and Children's Services. The cost impact is as follows. State costs, $9,804,132. Federal cost, $12,581,173. And the total cost is $22,395,305. The Qualified Residential Treatment Program rate and budget estimate have been developed based on various factors, including the Bureau of Labor Statistics salary tables, historical expense reports, and an estimated number of children that could be treated in the Qualified Residential Treatment Program. An opportunity for public comment was held on June the 8th, 2024 at 11:30 a.m. via Zoom. Written comments were due on or before June 25th, 2024. The public comment period yielded no oral or written comments. Given the comprehensive development of the QRTP and the absence of public comments and objections, I respectfully request that the board approve the final adoption of the Qualified Residential Treatment Program rate development. Thank you for your attention and consideration, and I'm available for any comments.
Thank you, Maxine. Any questions, comments from the board, please? Hearing none, is there a motion for approval for final adoption?
Motion for approval, David Cruz.
David Cruz made the motion for final adoption approval. Is there a second?
Second, Cynthia Rucker.
Dr. Ruckers has seconded that motion. All in favor, say aye.
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 Opposed? Abstaining? Hearing none, it is approved, Maxine. Thank you very much.
Thank you, Chairman Boyd.
Next two items, final two items to be considered, will be presented by Dr. Holloway, the Director, Deputy Executive Director and Senior Medical Director. Dr. Holloway, you may proceed.
Thank you. Good morning, Mr. Chairman and board members. As mentioned, my name is Dr. Kelvin Holloway, and I am the Deputy Executive Director and Senior Medical Director of the Department of Community Health. Pending approval by the Centers for Medicare and Medicaid Services and the Department of Community Health Board, DCH proposes to increase the professional dispensing fee for $11 to $11.50 for independent pharmacies with a prescription claim volume of greater than or equal to 65,000 per year, coverage effective July 1st, 2024. The cost impact has been provided for state fiscal year 2025. State funds, $315,064. Federal funds, $611,664. Total funds being $926,729. An opportunity for public comment was held on June 20th of this year, with written comment due on or before July 27th, 2024. The department did not receive public or written comments for this proposal. I respectfully ask for the board's favorable consideration of this item for final adoption, and I'll pause at this time for questions.
Questions, comments from the board, please?
This is Hopkins. This may be not pertaining to this particular presentation, but are we engaged in on the abuse by these pharmacy benefit programs? Are we dealing with that at all? Because I don't know if you've kept up with the most recent press on it. It's been a problem for a long time. These PBMs are abusing the system and hurting our independent pharmacists. Are we engaged in that at all?
I'll allow my other colleagues to possibly address that, Mr. Chair, if it's desired.
Dr. Holloway, this is Russell Carlson. Again, sorry for being remote, but thank you, Dr. Hobbs. We literally, the answer is I'm tracking some of the recent reports and publications of varying degrees coming out literally this week. So we've been in discussion a lot of that. We've also on both the Medicaid and SHBP side, especially following the legislative session, have been discussing PBMs and independents and without losing sight of the impact to our members too, to make sure that we preserve a plan that makes sense for our members as far as a premium and coverage dynamic. So we literally were on the phone with the independents, their association yesterday, talking through some of these matters, both the dispensing fee matters with SHBP, but also just the general dynamics of discrepancies and what the information really shows. We do have an actuarial study underway specific to the SHBP population following session. So what we're first trying to do is get some actuarially sound data before us and try to look at the plans both on Medicaid and SHBP and see what the lay of the land is and assess what our options are. So you're right, Dr. Hopkins, it's been a lot of real time as far as publications and reports, and that's been circulating a great deal, and we don't have our head in the sand. We're trying to kind of assess what all this means for our members. So I appreciate you bringing it up because it's definitely a live issue to say the least.
Well, thank you very much. I hope we can get on top of it.
Yeah, and I was going to say, this is Shane Mobley. It's incredibly unfair what the PBMs are doing. I know for a fact we've had 4 pharmacies to close this year in Georgia. And, some of these drugs and some of the reports that I've gotten back, Mr. Commissioner, where CVS, they may get $40 for a drug, which is pretty rich on their side, considering that they're the ones that have the direct contracts, and they're forcing these pharmacies, and some of the pharmacies are getting paid like $1.17 for the same drug, $1.50 for the same drug. So they're getting paid a lot less than what CVS is paying themselves. So I'm hoping that we can do something from a state level to where the people who are doing these contracts for these small pharmacies are the ones who are actually enriching themselves. And they're trying to force everyone to go to the large pharmacy centers, which, some of these places, Mr. Commissioner, are like in Alabama. They're not even in our state. And they're forcing our people here to have drugs shipped in from places in other states straight into our state and starving our small pharmacies out, which is really just not good. They need to make a living. Some of these pharmacies are having to do side hustles within their pharmacy, selling baked goods and stuff like that, just to stay afloat. So I'm hoping we can keep this a hot topic and we can do something about this and make this fair. What I want to see is that CVS, Walgreens, these other companies, they cannot pay the small local pharmacy 1 penny cheaper than they're paying themselves. And then we'll solve this problem. And then people can start making a living again. I personally know a pharmacist who has to him and his wife, they own a pharmacy. He literally has to go work at a hospital just to make ends meet, to stay in that small town. So we've got to do something about this. And I appreciate the work that we're doing so far, but we've got a lot more work to do. That's all I have to say about that.
Yes, sir. Thank you, Mr. Mobley. We like I said, we're definitely aware of a lot of these dynamics and working to like I said, first things first, have our actuarial study, which is again beginning to get out in the field, and we'll try to stay on top of what the information shows and make sound decisions and especially from an SHPP perspective, never lose sight of what a potential impact would mean for our members. So I never want to lose sight of that. But I value everyone's input, and we've been having our conversations with everyone too. Thank you.
Any other questions, comments from the board, please?
This is Dr. Coles.
Yes, Dr. Coles.
Are we to vote on this?
Yes.
Well, I would suggest maybe we table this vote until we get further information, because I've heard the same stories about the small pharmacies myself. I live in rural Georgia, and I see this as a problem. And I'm not real fond of kicking the can down the road, but this is a problem. I would personally like to see, like others have spoken about, that we make sure that we are watching after the small private pharmacies and the mom and pop shops, and particularly in rural Georgia, where you won't find a lot of CVS's and Walgreens.
Dr. Coles, I appreciate it, and I would just submit for the group, for everyone, the board and the public, that the item before Dr. Holloway is presenting before us now is actually a dispensing fee for the Medicaid side that would go to the independent pharmacists. This was a legislative priority in the budget, so it's been funded and worked through the appropriations process. So I would submit, Dr. Holloway, please, comment further if you see the need, but this is a dispensing fee that the legislature asked to go to the independent pharmacists, separate, if you will, than some of the conversations surrounding reimbursement, PBMs, perceived discrepancies in reimbursement. So it's germane to discuss the PBM issue just for reimbursement in general, but I would submit for your consideration that this item technically that is pending before us now actually pertains to a dispensing fee, which is commonplace. We're working on one right now with SHBP that goes to the pharmacists for every dispensing of medications to the customers.
Yeah, it's Dr. Coles again. Thank you for that clarification.
Mr. Chairman, if I might,
Yes,
just to
please.
make the committee aware that this indeed would be beneficial because it represents an increase in dispensing fees for the independent pharmacies that are low volume as far as prescriptions are concerned. We mentioned the cut point and threshold of equal to or less than 65,000. The current dispensing fee is $10.63, and what's being proposed is $11.50. So this would go to address the expenses above and beyond that of the drug itself. So this indeed is for the potential benefit of the low volume pharmacists.
Ms. Hopkins moved to approve.
I'm sorry, I didn't hear the comment.
Motion to approve.
You make the motion to approve. Is that right, Dr. Hopkins?
That's correct.
Okay. Motion has been made for approval of final adoption. All in favor say aye.
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 Opposed? Abstaining? Hearing none, it is approved, and we'll look forward to more information on this as has been suggested. Thank you. Dr. Holloway, you may move to your next item.
Thank you, Mr. Chairman. Once again, pending approval by the Centers for Medicare and Medicaid Services, the Department of Community Health proposes to amend its state plan to allow for an add-on payment to psychiatric inpatient claims for certain long-acting injectable antipsychotic drugs, effective with dates of service beginning July the 1st, 2024. The state fiscal year 2025 fiscal impact, state funds, $2,709,288, federal funds, $5,259,792 for the total funds for state fiscal year 2025 being $7,969,080. An opportunity for public comment was held on June 21st of this year, with written comments due on or before June 28th. The department received one public comment from Teva Pharmaceutical requesting UZEDY be added to the list of long-acting injectables for reimbursement in a hospital inpatient setting. At this time, the department declines to add additional products eligible for the hospital add-on payment for independent use. UZD is available on the department's preferred drug list and provider-administered drug list for outpatient use. Written comments were not received. I respectfully ask for the board's favorable consideration of this item for final adoption, and we'll pause for any questions.
Dr. Holloway, the recommendation for including another item or items in this list, and you say it's declined, and I wasn't quite clear on what the response was as to why that was declined.
It's make reference that this particular drug is available, and it's available on the department's preferred drug list. So there is access for being able to utilize this as a preferred drug. So that's the rationale for it being declined in this particular setting. There are 10 other drugs that are available on this setting that is being put forward for consideration.
Thank you. Any other questions, comments for Dr. Holloway, please? Hearing none, is there an approval for final adoption?
Folsom, motion for approval.
Roger Folsom made the motion for approval. Is there a second?
Second, Cynthia Rucker.
Yeah, Dr. Ruckers had seconded that. All in favor, say aye.
Aye.
Opposed? Abstaining? Hearing none, it is approved. Thank you, Dr. Holloway. Thank you. It might be appropriate to make a comment now, especially with the newer members of the board. We throw around, or a lot of these approvals have a lot of dollars involved. And that is a result, correct me if I'm wrong, Joe, but the dollars that we propose as a department are consistent with the budget approvals from the legislature and the governor's office. Is that correct?
That's correct, Mr. Chairman. So all these items that we have approved have come to us through the appropriations and have been approved and are recommended through the legislative acts.
Okay, thank you. Next and last item on our formal agenda here is a update on House Bill 663 by our General Counsel, Melanie Simon, and I'll add my congratulations on your 10 years of service to DCH. So Melanie, please.
Thank you, Mr. Chairman, members of the board and Commissioner Carlson. I will be providing an update on the department's implementation of House Bill 663. House Bill 663 is known as the No Patient Left Alone Act. It was passed during the most recent session of the Georgia General Assembly and signed into law by Governor Kemp on May 6, 2024, with an effective date of July 1st, 2024. The No Patient Left Alone Act establishes visitation rights for individuals admitted to hospitals and long-term care facilities. Long-term care facilities include nursing homes, intermediate care homes, assisted living communities, personal care homes, community living arrangements, and inpatient hospice facilities. The visitation rights allow patients and residents to have access to in-person visitation with essential caregivers and other visitors at these facility types. The Act authorizes facilities to impose visitation policies and implement visitation policies with reasonable safety protocols and rules of conduct, and to revoke the visitation rights of any essential caregivers or other visitors who are non-compliant with such requirements. In addition, facilities are not required to give visitors access to restricted areas of the facility, such as operating or isolation rooms. The Act does not prevent facilities from complying with Centers for Medicare and Medicaid Services regulations in the event that those regulations conflict with this state law. The Act requires DCH to develop informational materials on the No Patient Left Alone Act and to make these materials available to hospitals and long-term care facilities. The facilities must then post this information on their website. The facility is not required to create a website, but if they have a website, they must post these materials. The information and materials were developed by the Division of Healthcare Facility Regulation and are now available on the main page of the DCH website under Latest News. There are 2 flyers available, a 1-page summary of the act and a 2-page summary of the act. The content is identical in both versions, and posting either of these flyers will satisfy the requirements of the law. Facilities subject to the act are encouraged to post one of these flyers on their website as soon as possible in order to be in compliance with state law. The department also has shared the informational materials with the Department of Public Health, the Department of Behavioral Health and Developmental Disabilities, the Department of Human Services, and several healthcare associations. The department appreciates the assistance of our sister agencies and these other organizations in further disseminating these important materials. I'd also like to thank Lexi Turner with the DCH Office of Communications, who developed the design of the materials and was very helpful in that regard. No action is required by the board today on this item, but I'm happy to answer any questions.
Any questions, comments for Melanie from the board, please? Hearing none, thank you very much for that update, Melanie. Thank you. At this time, is there anyone who knows of any new business that needs to come before the board at this time? Hearing none, I'll remind you that our next meeting is August the 8th. And actually in August, we will have 2 board meetings, which is traditional. We have only 1 month of the year do we have 2 meetings, and that will be in August. And historically, 1 meeting, I think the first one will be, the primary subject will be budget and review of the budget proposals. And the second meeting in August, 2 weeks later, will deal primarily with the state health benefit plan and its any changes that may be made in that plan or proposed changes. And that will require a vote on on the structure and the rates proposed in that benefits program. With that, if there's nothing else that needs to come before the board, the meeting is adjourned, and thank you so much for your participation this morning. Thank you.
Thank you, Mr. Chairman.